Total knee arthroplasty is the most commonly performed joint replacement in the United States, over 700,000 procedures per year. This is my core product conversation. Marcus Chen, SynTera Orthopedics. The Pinnacle Total Knee System has three primary components. The femoral component, cobalt chromium, replaces the end of the femur. The tibial baseplate, titanium, sits on the resected tibial plateau. The polyethylene tibial insert, ultra-high molecular weight polyethylene, sits between the metal components and bears the articulating load. The patella button is optional. Not all surgeons resurface the patella. That's a clinical judgment call that I don't make. What I know: Pinnacle has 7 femoral sizes, 7 tibial sizes, and 4 poly insert thicknesses. That's a combination matrix of hundreds of size pairings. Getting the right combination into the OR before the surgeon resects bone requires knowing the pre-op templating, the X-ray measurements the surgeon uses to estimate size. The clinical differentiation: Pinnacle's femoral geometry is designed to reproduce the native posterior condylar offset more accurately than our primary competitor, which translates to improved flexion and stair-climbing outcomes in registry data. That's a conversation I have with surgeons in the clinical literature, not a claim I make off-label. Cemented or cementless, that's another choice point. Cementless gets used in younger, higher-activity patients with good bone quality. Cemented is the standard for older patients. Agentforce templates link surgeon preference cards, size preferences, cement vs cementless, patellar resurfacing, to each contact record. Total knee arthroplasty, clinical context and commercial volume. Total knee arthroplasty, TKA, is the surgical replacement of the diseased knee joint surfaces with prosthetic components, primarily indicated for severe osteoarthritis OA that has failed conservative management, physical therapy, intra-articular injections, NSAID. TKA is the highest volume elective orthopedic procedure in the U.S., with approximately 700,000 procedures performed annually, projected to reach 1.2 million by 2030 as the U.S. population ages. The procedure has demonstrated long-term effectiveness in pain relief and functional improvement in appropriately selected patients. For an orthopedic rep, TKA volume represents the commercial engine of the territory, the majority of elective joint replacement cases, and knowledge of the procedure, its components, and the surgeon's technical preferences is fundamental to the rep's value in the OR and in clinical conversations. Pinnacle TKS component architecture: femoral, tibial, and poly. The three-component structure of a total knee system, femoral component plus tibial baseplate plus polyethylene insert, defines the intraoperative decision set that a rep must master. The femoral component, cobalt chromium alloy, replaces the distal femoral articular surface and the femoral condyles. It is available in multiple sizes to accommodate the range of human femoral anatomy. The tibial baseplate, titanium with a porous coating for cementless fixation, or a polished undersurface for cemented, replaces the proximal tibial articular surface and provides the platform for the polyethylene insert. The polyethylene tibial insert, UMUP, ultra-high molecular weight polyethylene, provides the articulating bearing surface between the metal components and is the wear component most closely associated with long-term implant survivorship. Insert thickness determines the stability and gap balance of the reconstructed joint, an intraoperative decision made with trial components before final implant selection. Surgical templating and preoperative size planning. Total knee arthroplasty requires preoperative templating, a radiographic planning process in which the surgeon measures the patient's femoral and tibial anatomy on standardized AP and lateral X-rays, with a known magnification marker, and overlays size templates to estimate the correct component sizes. The surgeon generates a templating sheet specifying their predicted femoral size, tibial size, and insert thickness. The rep uses this information to confirm that the correct sizes are available in the consignment tray before the case, and to have backup sizes staged and ready if the intraoperative anatomy deviates from the preoperative estimate. A rep who knows Dr. Kaufman's templating tendencies, consistently one size smaller than the templated femoral size in female anatomy, prefers thicker poly inserts in varus deformities, can anticipate intraoperative needs better than a rep following the pre-op sheet alone. Cemented vs. cementless fixation, the clinical decision with commercial implications. Total knee implants can be fixed to bone through two mechanisms. Cemented fixation, using PMMA bone cement, typically including an antibiotic agent such as SynTera, or cementless fixation, relying on bone ingrowth into a porous metal coating on the implant surface. Cemented TKA has the longest survivorship data, 20-plus year follow-up from landmark studies, and is the standard of care for older, lower-demand patients. Cementless TKA is gaining adoption in younger, higher-activity patients where biological fixation may offer superior long-term outcomes if bone ingrowth is achieved. From a commercial perspective, cemented cases require cement, SynTera, a revenue line, while cementless cases do not. Reps who understand the surgeon's patient selection criteria for cementless can anticipate cement utilization and inventory needs accordingly. Surgeon preference cards and agentforce clinical profile management. Each surgeon who performs total knee arthroplasty maintains a preference card, a documented specification of their preferred component sizes, fixation methods, patella management approach, and supplementary supplies for a standard primary TKA case. The preference card is the ordering document. SBD uses it to assemble the tray, the circulating nurse uses it to pull supplies, and the scrub tech uses it to set up the back table. A rep who has digitized every surgeon's preference card in agentforce and keeps those records updated as preferences change can verify tray completeness before any case without calling the surgeon or coordinator. This proactive preparation reduces case delays, demonstrates operational value to staff, and protects the rep against last-minute inventory surprises. Total hip arthroplasty is technically more forgiving than total knee most of the time. Revision hip is not. Marcus Chen. SynTera Orthopedics. The Apex total hip system has 4 components: acetabular shell, liner, femoral stem, femoral head. That's the primary construct. The acetabular shell is titanium hemispherical with a porous coating on the outer surface for bone ingrowth. It press-fits into the reamed acetabulum. The liner, polyethylene, ceramic, or metal, locks into the shell. The femoral stem is titanium, press-fit into the femoral canal. The femoral head, cobalt chromium or ceramic, connects to the stem taper and articulates against the liner. The bearing surface choice is the conversation I have most with surgeons. Metal on poly, proven, cost-effective, good survivorship. Ceramic on poly, lower wear, better for younger patients, reduces osteolysis risk long-term. Ceramic on ceramic, lowest wear, but fracture risk and squeaking. The right choice depends on patient age, activity level, and surgeon preference. What separates primary from revision? In a revision, the surgeon removes a previously implanted prosthesis. The bone bed has been compromised. Defects need to be filled. We use augments metal blocks to reconstruct bone loss. Extended offset stems for deformity. Anti-protrusio cages for severe acetabular deficiency. My revision tray is 3 times the size of my primary tray. Revision cases take 2 to 4 hours. I'm in the room the whole time. Agentforce logs primary vs revision mix per account. Revision-heavy accounts need extended tray sets on consignment. Total hip arthroplasty, primary construct and component architecture. Total hip arthroplasty, THA, replaces the diseased hip joint with a modular prosthetic system that recreates the ball-end socket articulation of the native hip. The 4-component construct consists of 1. Acetabular shell, the outer cup component, press-fit into the reamed acetabulum, providing the structural platform for the bearing surface. 2. Acetabular liner, the inner articulating surface, polyethylene, ceramic, or metal, locking into the shell. 3. Femoral stem, the component press-fit or cemented into the femoral medullary canal, providing the foundation for the femoral head. and 4 femoral head, the ball component that articulates against the liner, available in multiple sizes, 28 mm, 32 mm, 36 mm, 40 mm diameter, to optimize stability and range of motion. Component selection, particularly liner material, head size, and stem fixation method, is individualized to patient anatomy, bone quality, age, and activity level. Bearing surface options, the surgeon-facing clinical differentiation conversation. The bearing surface, the combination of femoral head material and liner material that determines how the joint articulates, is the most clinically debated component selection in total hip arthroplasty. Metal-on polyethylene, MOP, cobalt chromium head on UMUP liner, the historical gold standard with 20-plus year survivorship data, produces small particle polyethylene wear debris that drives osteolysis over time in active patients. Ceramic-on polyethylene, CoP, alumina or zirconia ceramic head on UMUP or highly cross-linked UMUP liner, lower wear rates than MOP, reduced osteolysis risk, preferred for younger and more active patients. Ceramic-on ceramic Co-C, ceramic head on ceramic liner, lowest wear rates of any bearing combination, but carries a small risk of catastrophic liner fracture and a distinctive audible squeaking phenomenon that some patients find distressing. Metal-on metal, MOM, largely abandoned following the hip resurfacing ion release controversy of 2010-2012, largely contraindicated in primary THA, revision hip arthroplasty, clinical complexity and commercial differentiation. Revision THA, the removal and replacement of a previously implanted hip prosthesis, is substantially more complex than primary surgery. Bone loss from where debris-induced osteolysis, paraprosthetic fracture, or implant loosening creates defects in the acetabulum and proximal femur that must be reconstructed before a new prosthesis can be fixed. Reconstruction tools include bone graft, autograft from the patient or allograft from a bone bank, metal augments, titanium wedge or block augments that fill acetabular defects, trabecular metal porous tantalum, augmentation for severe defects, anti-protrusio cages for acetabular discontinuity, and extended offset or modular femoral stems for complex femoral anatomy. The Apex revision system requires a substantially larger instrument set than primary THA, 3 to 4 times the tray count, and demands higher technical proficiency from both the surgeon and the supporting rep. A rep who can navigate a complex revision case without adding to the surgeon's cognitive load has earned a different level of trust than a primary case-only rep. Hemiarthroplasty configuration, the trauma application. In addition to full THA, the Apex system includes a hemiarthroplasty configuration used primarily for femoral neck fractures in elderly patients. A hemiarthroplasty replaces only the femoral component, stem plus head plus bipolar cup, while leaving the native acetabulum intact, avoiding the longer operative time and greater surgical complexity of a full THA. Bipolar cups, a mobile inner bearing that reduces acetabular wear by allowing motion between the head and cup, are the standard femoral neck fracture configuration for the Apex system. Hemiarthroplasty cases from trauma call represent a distinct commercial and clinical scenario from elective primary THA. Different patient population, elderly, higher ASA score, increased comorbidity, different time pressure, surgery within 24-48 hours of fracture to reduce mortality risk, and different instrument set requirements, Apex system sizing and offset optimization, the rep's intraoperative value. Femoral stem selection in THA involves not just size but offset, the horizontal distance from the femoral stem axis to the center of the femoral head, which determines abductor muscle tension, leg length equality, and joint stability. The Apex system offers standard and high offset stem configurations in each size. Intraoperatively, the surgeon trials multiple stem sizes and offset options to optimize leg length equality and stability before final implant selection. The rep who understands the relationship between stem offset, acetabular cup position, and head size in restoring hip mechanics, can communicate with the surgeon in real time about which combination of trial components best restores the patient's anatomy. A level of technical dialogue that requires both product knowledge and anatomical understanding. A surgeon who has been using the same knee system for 8 years is not going to change because I walked in with a brochure. Marcus Chen, SynTera Orthopedics. Dr. Reyes has been a striker triathlon surgeon since his fellowship. He's comfortable, he's efficient, his outcomes are good, his OR team knows the tray. There is no clinical or operational reason for him to change. My strategy: I'm not trying to replace Stryker. Not yet. I'm trying to earn a case. I invited him to the SynTera ankle-to-ankle anatomy lab at Texas Scottish Rite, a teaching case where we covered Pinnacle's instrumentation alongside the triathlon for comparison. He got hands on both systems. He noted that Pinnacle's tibial resection guide is adjustable in a way his current system isn't. 3 weeks later, I asked if he'd consider using the Pinnacle system on one appropriate case. A straightforward primary knee, good bone stock, no deformity, lowest technical risk. He agreed. I had the tray confirmed the day before. I was in the room at 6:45. Conversion is a process. One case becomes two, two becomes a mix becomes primary. It takes 6 to 18 months to convert a committed surgeon from a competing system. What speeds it up? Exceptional case support. Product performance the surgeon observes personally. Competitive pricing. And a rep who is in every room every time without exception. What slows it down? One missed case. One wrong implant pulled. One moment where the competing rep covered something I didn't. Agentforce tracks competitive case mix by surgeon. What percentage of each surgeon's cases are Pinnacle vs competitor? The conversion timeline. Why displacement takes months, not calls. Surgeon conversion from a competing implant system to a new system is a protracted commercial process, not a transaction. A surgeon who has used the same implant system throughout their career has accumulated procedural memory. The muscle memory of the instrument sequence, the tactile familiarity of the implant's feel, the confidence of knowing exactly what to expect when the femoral component seats. This investment of experience creates a switching cost that has nothing to do with product quality. Even if the alternative system is objectively superior, the surgeon must accept a temporary reduction in procedural efficiency while building new procedural memory. The conversion timeline, 6 to 18 months from first trial case to primary use, reflects this learning curve. And a rep who understands this timeline is patient with the process, rather than expecting immediate volume commitment after a successful first case. The anatomy lab/cadaveric evaluation as the conversion trigger. Orthopedic surgeons make product decisions based on tactile experience, not sales presentations. The most efficient conversion trigger is a hands-on opportunity to evaluate the competing system in a low-stakes environment. A cadaveric anatomy lab where the surgeon can execute the full instrument sequence on a specimen, make size decisions, and form a direct comparison with their current system. SynTera hosted anatomy labs with an AdvaMed code parameters, educational purpose, appropriate venue, documentation of educational content, modest associated hospitality. Give surgeons the experiential basis for a conversion decision that no amount of promotional material can provide. A surgeon who has personally trialed the Pinnacle tibial resection guide and found it technically superior to their current system has an internal rationale for the switch that is far more durable than any external commercial argument. The conversion case, the highest leverage event in the relationship. The first case using a new implant system is the defining event in the conversion relationship. The rep's execution on the first case, tray completeness, early arrival, confident instrument identification, zero friction or experience, creates the impression that anchors the surgeon's early experience with the new system. An impeccably supported first case that goes smoothly confirms the surgeon's decision to trial the system and lowers the barrier to a second case. A first case with a problem, a missing poly insert size, a confusing instrument, a late-arriving rep, creates a negative data point that the surgeon files against the new system regardless of the root cause. First case preparation is the highest ROI investment of time and attention in the entire conversion process. Tracking competitive case mix, the share lens on conversion progress. A surgeon's conversion progress is most accurately measured by tracking their case mix over time. What percentage of their knee and hip cases are performed with SynTera systems vs. competitor systems? A surgeon who has trialed 2 Pinnacle cases but still performs 90% of their volume with Stryker is a conversion in early stages, not a converted surgeon. A surgeon at 60% SynTera/40% Stryker is an active transition and may be using both systems for different patient types or indications. A surgeon at 95% SynTera who uses Stryker only for specific cases, e.g., complex revision cases where their primary training was in the competitor system, is converted for primary purposes. Tracking this mix over time, case by case, month by month, allows the rep to identify conversion progress, stalls, and reversals. Agentforce competitive analysis fields track surgeon-level competitor product usage alongside SynTera case history. What stops a conversion? The rep's operational failures as competitive weapon. In orthopedic devices, the most common reason a surgeon conversion fails is not clinical preference for the competitor's product. It is operational failure by the converting rep. A missed case, rep not present when the surgeon needed support. An incomplete tray, missing size requiring or delay or improvisation. A consignment restocking failure, empty slot on the second procedure, or a scheduling conflict, rep covering another account when the surgeon was operating. Each creates a negative data point that the competitor's rep does not have to refute. The operational failure refutes itself. Surgeons who are converting to a new system are forgiving of genuine product learning curves, but unforgiving of logistics failures that create procedural disruptions. The competitive rep who covers every case at their account, restocks immediately, and is physically present without fail, creates a service standard that the converting rep must match or exceed to sustain the conversion.